Hi everybody, my name is Michelle. I am the current oncology pharmacy resident, and I'm going to be giving a brief overview on pain management in the hospice care setting today. I wanted to start out with a little bit of general background information about pain before getting into the treatment options specifically. So this slide here just discusses the definition of pain as being an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And it also mentions that clinicians should acknowledge and treat both physical pain and non-physical factors, and those non-physical factors for your reference are listed here in the chart below. Next, I wanted to discuss the prevalence of pain and the types of pain that are common end of life. So really, pain at the end of life is pretty common. It's estimated at about 51% of people, and it is increased in the last month of life. Bone metastases is a really common cause of pain in cancer patients, and in other patients with non-malignant pain, headache, and lower back are the most common causes typically. Next, I wanted to discuss a few different classifications of pain. This slide here talks about acute pain, subacute pain, and chronic pain. So those are a few different ways to classify pain. A few other ways to classify pain, which we will discuss more in depth in the coming slides, are nociceptive pain, nociplastic pain, and neuropathic pain. Nociceptive pain can be either visceral or somatic. Visceral pain mainly affects the internal organs, and some examples of that would be constipation and tumor involvement in the organ capsule. And then somatic pain mainly affects the muscles, skin, and bone, and examples of that are bone pain or swollen ankles. Neuropathic pain is generally a pain sensation that could be burning, prickling, tingling, pins and needles, things like that. This can be either central, with examples of that being spinal cord or brain injury, or peripheral, with an example of that being diabetes. Lastly, we have the nociplastic pain that we mentioned. This is a mixed pain state, so it's a mixture of nociceptive and neuropathic pain. And examples of this are fibromyalgia or chronic lower back pain. Along with the different classifications of pain, I also just wanted to briefly mention the different phases of pain. These are shown here in the image to the right. I'm not going to go too in depth with any of these, but I just wanted to mention these so you would know that there are 4 phases of pain. These are transduction, transmission, modulation, and perception. The last portion of the background that I wanted to discuss is the pain assessment. It is important to always conduct a thorough assessment before starting or giving any pain treatment to patients, and there are some assessment considerations listed here for you on this slide. There are various pain assessment severity tools. These tools are intended to help healthcare providers assess pain based on specific patient need. They are broken down on this slide between neonatal, infant, and child pain scales for adults, and pain scales for nonverbal or cognitively impaired adults. The ones that we mainly would deal with in the hospice house are these pain scales for adults, so ones we may be familiar with are the 0 to 10 numeric ruler, and then the pain ad is a good one for nonverbal or cognitively impaired adults that we use. I have also seen the FLAC behavioral pain assessment scale used, but I just wanted to note too that that is really a neonatal, infant, and child pain scale. This slide visually shows some examples of the pain assessment severity scales. The top one is the numerical rating scale that we mentioned, and the second one is the FACES pain rating scale. And this scale shown here is the pain assessment in advanced dementia, or that pain ad scale that we mentioned. Now that we have briefly discussed some pain management background information, I'm going to discuss treating pain in the hospice setting. First, I wanted to start briefly touching on the non-pharmacological therapy options. This is really important to keep in mind as it is essential for chronic pain management, and it also could be beneficial for acute pain. There are multiple examples of this non-pharmacological therapy listed below in the chart for your reference. Next, I will move into discussing the pharmacotherapy for pain management. I wanted to start out with a few general rules of thumb for pain management. It really should be based on the patient's reported and observed pain level using those assessment scales we have discussed. It should also be given around the clock if they have any chronic pain, and it should be given by the least invasive route, which in general would be oral, so we would prefer the oral route. And then lastly, it should be tailored to the specific individual in pain. Next, I'm just going to talk about general pharmacotherapy recommendations with mild pain, moderate pain, and severe pain. So I'm going to start with mild pain, and in general, it's a good rule of thumb that we prefer our non-opioid or our other pain treatment options first to try to control pain. So for mild pain, they say to try a non-opioid with or without adjuvants and non-pharmacological interventions. For moderate pain, we can consider adding additional options to that mild pain backbone we discussed. So here they have some similar recommendations, with there being the with or without adjuvants and non-pharmacological interventions, but they add considering an opioid with or without a non-opioid analgesic, could consider tramadol and or could consider tapentadol here. Lastly, for severe pain, it's again very similar. Here they changed the potential opioid to being a pure opioid, and then again it could be with or without a non-opioid analgesic, with or without adjuvants, with non-pharmacological interventions, and with the recommendation of also having psychosocial support. Next, I wanted to discuss specific options for analgesics for management of those different types of pains we discussed in the background. So this specific slide discusses the analgesics for the management of nociceptive pain. It starts out talking about acetaminophen and NSAIDs as being options. Those are our preferred options as non-opioids if we can get through with those. Other options are opioid combination products as listed, those atypical opioid monoamine reuptake inhibitor analgesics that we discussed, the opioid mixed agonist-antagonist, buprenorphine is an option, and then our pure opioids are options, with methadone being our preferred option, as we'll touch on later in the coming slides. In this next slide, I wanted to continue discussing the analgesics for management of nociceptive pain, but in just more specific settings. So the first bullet point talks about colicky, cramping, visceral pain. So medications good in that setting typically are dicyclamine, glycopyrrolate, hyoscyamine, and scopolamine. The second bullet point is for bone pain or stretching or capsule visceral pain. Medications that typically work well for that are dexamethasone in general, methylprednisolone, and prednisone are also options. Lastly, specifically for bowel obstruction colic pain, you may see octreotide used in other settings, but this is actually not used much in hospice. The reason behind that is it's an injection, so that could cause pain, and it is a little bit more costly. So instead, in our hospice setting, we typically use haloperidol or dexamethasone to help with a bowel obstruction pain. Now I will transition to discussing the analgesics for management of neuropathic pain. These medications that typically work well for managing neuropathic pain are listed here. Generally, our anti-epileptic drugs, especially gabapentin and pregabalin, are helpful for this type of pain, as well as serotonin norepinephrine reuptake inhibitors such as duloxetine and venlafaxine. And then our opioid that is beneficial with this type of pain is methadone because of its action on the NMDA receptor, which we will see in the upcoming slides. Other options are local anesthetics, topical analgesics, and lastly are tricyclic antidepressants. However, those tricyclic antidepressants do have a lot of side effects that we would not generally like to have patients experience, so those would be really last line. At Monument Health Hospice, we do also have our own hospice admission and comfort pack order, which has specific pain medications included. These pain medications are listed here below in the image. For mild pain, we have acetaminophen on there, and then for pain that is higher than that, we have an option for as-needed morphine that starts out with a lower dose and has directions to increase if the response is not adequate. So because of these specific orders, it is important to activate the hospice pain orders for pain management on any hospice patient so we can have these specific orders for our patients. And it is just important to pay attention to, and for me to mention, that non-opioids in general are more preferred first line for pain. They generally are more effective, and we just want to avoid the opioids where we can. As in the morphine instructions, we do want to start low and titrate to increase doses as needed. And it is important to note that if a patient is having high opioid requirements, you would want to reach out to the pharmacist and/or provider, as at this time the patient would likely need something additional for pain management. And as you can see, the morphine is more preferred. It is our preferred as-needed opioid at Monument, just mainly due to it being more cost-effective than oxycodone. To continue on the as-needed opioid dosing discussion, I wanted to point out a few more caveats. If using long-acting opioids, there always needs to be an as-needed opioid ordered for breakthrough pain, and this breakthrough opioid dosing should be about 10 to 20% of the 24-hour oral opioid equivalent at the recommended interval for the patient. It is also really important that patients and caregivers are keeping accurate pain logs. This can help us assess their pain control and assure that the doses of medications we're giving them are helping. If the patient is using about 3 to 4 or more as-needed opioid doses per day, this is the point where we would want to consider increasing the long-acting opioid or starting the patient on a long-acting opioid if all they have is an as-needed opioid at that time. Another pharmacotherapy option I wanted to go a little bit more in depth into to discuss some caveats is methadone. This is our preferred long-acting opioid. It has a unique mechanism where it binds to the opiate receptors in the central nervous system that helps to inhibit the ascending pain pathways and alter the perception and response to pain. And then it also has that NMDA receptor antagonism. It is a safe and effective option for hospice pain management when opioid analgesics are needed and the provider is experienced. But it does require caution and frequent evaluation, and I wanted to note it does have a long and variable half-life, as you can see here, and the time to steady state is about 5 to 7 days. There is also variability within a patient over time and between patients. Another methadone caveat is that in general, an electrocardiogram should be considered before initiation of therapy. However, this is different in the end-of-life care as it's generally not recommended in this setting or the hospice care setting. Methadone is available as an oral tablet, oral solution, and oral concentrate, so that is helpful in the hospice setting as that oral concentrate can be given sublingually if the patient is even not swallowing well. This may also have superior tolerability compared to other opioids in patients experiencing chronic pain, and it's a really cost-effective alternative to other opioids, and it does have good bioavailability. So those are other positives to using this medication. Another thing to note is just that methadone conversion can be complex and must be individualized for each patient, so that should be done cautiously. To help show the significant cost difference for why we use the morphine sulfate concentrate and the methadone concentrate as our preferred products, I wanted to include this cost breakdown here. This shows the oxycodone concentrate, morphine sulfate tablets, OxyContin tablets, and methadone concentrate, and you can see both the morphine sulfate concentrate and methadone concentrate are significantly cheaper than those other options. Given morphine is our preferred as-needed opioid for pain management, I wanted to just mention a few caveats on morphine in renal impairment. Metabolites may accumulate in patients with renal dysfunction. However, morphine is still used in patients with renal impairment for hospice care. We should just always monitor closely for increased side effects as signs of accumulation with use of morphine in renal dysfunction. Some of those signs are CNS depression, that's excess, confusion, sedation, respiratory depression, things like that. Another opioid which I felt was important to discuss in this presentation is fentanyl patches. The big point I wanted to make is that fentanyl patches are not ideal for hospice pain management. This is because the pain should be stable and well controlled on an opioid before starting a fentanyl patch, and that's generally not the case with our hospice patients. Fentanyl patches should only be used for opioid-tolerant patients, and the patches are not recommended for unstable pain requiring frequent dose adjustments. Transdermal fentanyl absorption is also impaired in cachectic patients, and many of our hospice patients are also cachectic. Lastly, I'm going to touch on some adverse effects of our pharmacotherapy treatment options. Listed here is a table of the opioid adverse effects, both common and uncommon. The one adverse effect I really wanted to point out and talk about today is constipation. This is very common with opioids, and patients do not develop tolerance to opioid-induced constipation. Because of that, all patients should have a preventative bowel regimen in place at initiation of opioids. So we should initiate stimulant laxatives plus a stool softener when a patient begins an opioid. This next chart shows some of the general side effects of other medications that we've discussed for pain management throughout this presentation. The main ones that I wanted to pull out are the cardiovascular and gastrointestinal effects or GI bleed risk with our NSAIDs, the CNS depression and issues with renal impairment and gabapentinoids, and potential for hyperglycemia and insomnia with glucocorticoids. That concludes my presentation on pain management in the hospice setting. Please let me know if I can help address any questions, and thank you for listening. Here are the sources I used to put together my presentation.